This is a short instructional video on how to do tonometry. Room lights must be dimmed throughout the examination. However, for the purpose of this video, they will be kept on. Eye care professionals such as orthoptists use tonometry to determine pressure inside the eye, which is known as intraocular pressure. Tonometry measures IOP through assessing resistance of the cornea when pressure is applied. Therefore, it is important that tests assessing the shape of the cornea, such as keratometry and corneal mapping, should be performed prior to tonometry. Normal tonometry values range between 10.5 and 21 millimeters of mercury. Various techniques such as applanation and indentation are employed in tonometry, with devices such as Goldmann, Perkins, Tonopen, and eye care.
Pocahontas! Pocahontas, can you hear me? Wake up! Wake up! Okay, what happened?
Oh, my head hurts. I must have hit it. I can't see very well.
I'm pretty sure we have an eye specialist on the ship. We'll take you there right away.
Hello, I'm Louise and I'm the orthoptist on the ship. So John has brought you in because he said you've been experiencing headaches and blurred vision, is that right?
Yep.
Okay, so that sounds like symptoms one has when they have an increase in intraocular pressure. So let's begin by checking your IOP. Okay.
In this video, we will be using the Haag-Streit Goldmann tonometer. However, there are other tonometers such as Tagaki that can be used. Equipment required. The equipment required to perform tonometry are slit lamp, tissues, hand sanitizer or alternatively soap, alcohol swabs, fluorescein strips, anaesthetic, tonometer and applanating prism. How to calibrate. The tonometer must be calibrated every 6 months. Calibration is done at the dial positions of 0, 2 and 6. This is equivalent to 0, 20 and 60 millimeters of mercury. Insert the bar into the tonometer head. At 0, if the dial is turned backwards, the prism arm will fall towards the examiner. If the dial is turned forwards, the prism arm will fall away from the examiner. The check weight bar is currently set at 0. Move it to 2. Make sure the longer end of the bar is facing the examiner. At 2, if the dial is turned backwards, the prism arm will fall towards the examiner. If the dial is turned forward, the prism arm will fall away from the examiner. Repeat this process for 60 millimeters of mercury. Slit lamp preparation. The tonometer head must be correctly placed onto the base. On the base plate there are 2 holes. You must place the protruding part on the bottom of the tonometer head into one of these holes. Make sure you hear the click and move it to check that it is firmly in place and stable. Switch the slit lamp on and turn it to the highest setting. Adjust the arm 60 degrees temporally from the eye being tested. Use the lever and set it to the open dotted circle. Use the slit width controls to set the beam to the widest. Dial until it is cobalt blue. Rotate the tonometer head dial until it is on 1. Also note that 1 represents 10 millimeters of mercury. Make sure the prism head is aligned at 180. If the patient has a corneal astigmatism that is greater than 3 diopters, align the patient's minus cylinder axes with the red line or A on the prism holder. Ensure your magnification is at 10. The examiner must adjust the IPD according to their interpupillary distance. They must then correct for the refractive error. Hygiene. First, the clinician must clean their hands to make sure it is sterile before they begin. Use alcohol wipes to clean the applanating surface and allow it to dry so you don't burn the cornea. In addition to cleaning the tonometer head, you must clean the headrest and the chin rest. When applying anaesthetic, make sure you read the label to check if it's a correct agent and the expiry date. Patient preparation.
Are you allergic to anything?
No.
Hold the cap in one hand whilst applying the drops with the dominant hand. Use your index finger to pull the lower lid down and ask the patient to look up. Make sure the bottle does not touch the eyelids, lashes. If so, throw the bottle away. Please provide patient with tissue. When opening the fluorescein strip, make sure your fingers do not come in contact with the orange tip. Tilt the patient's head back and ask them to look up. Gently pull down the lower lid and place a fluorescein tip behind the lower lid and against the sclera. Ensure you do not place too much fluorescein into the eye, as this may alter your Maya readings. Assessment.
So put your chin on that chin rest and your forehead on against the forehead rest.
Adjust the height of the table for maximum comfort for the patient.
You comfortable there?
Yep.
And align the black line with the outer canvas.
So look where my finger is and look at it all times.
Use two hands to move a slit lamp forward. Only use a joystick to refine movements. When you get closer to the eye, you can use a joystick to move the tonometer head up or down. Spin it clockwise to move the tonometer head up and anti-clockwise to move the tonometer head down. When moving the tonometer head forward, you must look at the patient's eye. It is when we are close to applanating the cornea that we must look through the eyepiece. If you note the Mayas are not centered while the cornea is applanated, use a joystick to move the tonometer head back and readjust. Ensure you begin with a dial at 10. Once you've applanated the cornea, slowly move the dial towards the patient until you see the Mayas align. Mayas. This is how Mayas should appear. Mayas should be slightly inside one another. As you can see, the Mayas have passed one another, and therefore the pressure has been overestimated. Turn the dial backwards to gain an accurate reading. This is an example of underestimation, as the Mayas haven't made contact yet. Turn the dial forward to gain an accurate reading. Having the correct amount of fluorescein is also important. Too much fluorescein will give thick Mayas and therefore an overestimation of IOP. A small amount of fluorescein will contribute to an underestimation due to thin Mayas. Additionally, if the Mayas are not equal in size, this indicates that the prism is not centered on the cornea. Pull the prism away from the patient's cornea and adjust accordingly. If the upper Maya is larger than the bottom Maya, twist the joystick anti-clockwise to bring the prism lower. If the lower Maya is larger than the upper Maya, twist the joystick clockwise to bring the prism lower. Once you have successfully recorded the intraocular pressure, move the tonometer head back and ask the patient to sit back.
You can sit back now.
Recording results. First we start by writing A, which represents applanation. To the left of the A, we write the pressure of the right eye, and to the right of the A, we write the pressure of the left eye. Beneath this, we write the time the pressure was taken. Pocahontas' pressures were within normal limits and was free to go. The pros and cons of Goldmann tonometry. The pros are: results obtained are reproducible, it is a painless procedure, it is of gold standard, it is highly accurate and a very efficient way of measuring an individual's IOP. The cons are: this procedure cannot be performed on individuals with watery eyes, there's a risk of abrasion and indentation, You do not perform this if an individual has a compromised cornea or if they have allergies to anaesthetic or fluorescein. This requires a skilled examiner and patient cooperation. Thank you for watching.